All right, folks, we're going to talk about endocrine. All right. And we'll go through on the slide and we'll kind of discuss what's the importance of the slide. But let's talk in the United States. There are approximately 38 million people with diabetes, representing about 11% of the population. This is huge when you think about it. And we're starting to have the age of enlightenment in diabetes is that just think of how hard diabetes is as a disease. Can you imagine even though you do everything you possibly can do correctly, trying to work on reducing your sugars, reducing your hemoglobin A1C, and you still can have complications. So we're starting to get newer drugs, better ways of monitoring it, but we still have a long ways to go. And it contributes so much to death, debility, morbidity, mortality of our patients. Just think about it. It's easier nowadays to have HIV/AIDS than it is to have diabetes. If your insurance, I want to say that dirty word, insurance, if your insurance is good enough, you could get 2 blood tests a year and take 1 pill a day. And can you imagine that with diabetes? People with diabetes would kill themselves, cut off their hand to get where they're not having to have all these tests, these invasive tests. I want you to go try and do finger sticks. I want you to do finger sticks for a week. I want you to do it 6 times a day, and I want you to go and you can rotate your fingers and try doing that and see how it feels, how that feels. Do it 6 times, 8 times a day, and do this for a couple weeks and see how you feel. And that's just one thing that they have to deal with. All right, so we're gonna get on diabetes. I wanna address this slide real quick. And I know it looks funny, and in some ways it's funny. The patient started cursing, demanding pain medication. I came to talk to the patient. She was verbally aggressive and started throwing stuff at staff. She kept replying, and there's a swear word there, you better get me something for pain. I tried to calm, but the patient became more aggressive. Security and ER notified. Patient left AMA, she refused medical care. She stated she would discharge and no further treatment at this time. When I informed the patient what the physician said, she started throwing things at the staff and threatened us and stated, if you don't give me any pain medications, I'm going to come and shoot all of you, and X word, X word, X word. This is a reality here in what we have in our current clinical environment. It probably worsened after COVID-19. And I personally experienced this, that one of the colleagues in the facility I was working at was killed before I came on shift. This was a gentleman who had over 20 to 30 years experience and was killed because the person he did a surgery on perceived that he didn't get enough pain medication. So I don't have great advice, and I hope that you never have a situation like this in your facilities, but the reality is you will. You need to be aware of your environment. You need to be aware of what your staff, to make sure you and your staff are protected. You need to have a plan, and you need to be able to work together if an incident happens, an unfortunate incident happens in your facility. These are things, unfortunately, they don't teach us in training, and there's no great simple advice. There's not a pill you can take. There's not a simple course you can do that you're going to protect you or your staff. These are things you need to be aware of and start thinking of is how are we going to prepare it if a situation happens. Now let's get on to endocrinology. This is a 27-year-old female with speech therapist who was found with past medical history of diabetes mellitus, was found on the side of the road. She was confused. She had Kuzelmel's breathing. Can you imagine being famous for the rest of the generations that you have described a breathing pattern where it's deep, fast breathing? Because what is she trying to do? Her body's acidic. She's trying to burn off and blow off that CO2. She's tachycardic and her mouth is dry. Her serum glucose was elevated, not crazy, it was 430. Her bicarbonate level, or serum bicarb was 12, and her NANOGAP was 20. What has she got going? Well, we're gonna go here to get an unfair board review question after a clinical snippet. We already know what this is, right? After initial fluid resuscitation, what is the most following appropriate next step in the patient? Administer intravenous insulin, give intravenous bicarb, treat the hyperkalemia, administer subcutaneous rapid-acting insulin analog, begin oral rehydration therapy. This is a 28-year-old female with type 1 diabetes who presented to the emergency department with 24 hours of nausea, vomiting, abdominal pain, and increased fatigue. She's reported polyuria and polydipsia. On examination, she's tachycardic, hypotensive, and has rapid, deep, shallow respirations. no, I'm sorry, rapid deep respirations, remove shallow from my wording. Labs show serum glucose of 420, pH of 7.12, serum bicarb of 10, and an ANGOP of 24 with positive serum ketones. Her potassium is 5.3. All right, so what's the answer to this? After initial fluid resuscitation, which of the following is the most important step in management? Well, what's the diagnosis? What's the disease? This is DKA, diabetic ketoacidosis. I want you to think of DKA as kind of change your mindset. I want you to think it's a storm in the body where there's multiple organ systems are involved. We talked about it, and we just in that clinical stem. She's respiratory. Look at this. She's breathing fast. Tachypnea, her cardiovascular. We're having the endocrine system affected. GI is also affected. So multiple system involvement. And they all kind of collide. And I want you to think this is a storm in the body. And the answer is going to be administer intravenous regular insulin. Bicarbonate we try to avoid that in most scenarios unless the pH is less than 6.9. We definitely don't want to treat the hyperkalemia. We'll discuss how probably the patient is hypokalemic totally in a total body hypokalemia, and then administer a subcutaneous rapid-acting insulin analog, not right now, and we don't want to begin oral rehydration therapy at this time because she has nausea and vomiting. So that we get the answer of what's going on. So let's talk about what DKA is. So DKA is a relative lack of insulin, and what does insulin do is it helps us get glucose into the cell. I want you to think of it as the transporter. Remember that movie, The Transporter? Your insulin is your bodyguard, your transporter, bringing glucose into the cell. Now, it puts the glucose 6-phosphate, so you get the glucose molecule, you put the 6-phosphate on there, boom, and you get the insulin to bring it in the cells. So what happens when we can't get insulin in the cells? We can't get glucose in the cells from the insulin. The body gets nervous because guess what? Those cells want energy and they need that energy. It's basically, don't you get nervous when you're driving your car and you're about to run out of gas and you'll be stuck in a bad area or stuck way far away from anybody that can give you help? And you're driving, you're getting really nervous. The same thing, the cells are getting nervous, getting signals. So what happens is our body makes ketones, which is a fuel. You can make ketones, just fast for a little bit. You can make ketones. And what happens when we have overwhelming amount of ketones? You can fast and have ketones, but if you're not having diabetes, you're gonna have some symptoms and then you'll eat some food, correct? But when the body makes ketones and you can adjust it, what are the side effects? Your body is acidic, you get nausea, vomiting, and pain. And in people, if you're able to correspond with them who are in severe DKA, they'll tell you that everything hurts, even their hair hurts. And I can give you an experiment. Back in the day, back in the 80s, they used to do a very strict ketone diet where basically you would strip any type of carbohydrate from your diet. So eating just fats and proteins for at least 5 days straight. And I implore you to try it because you can definitely lose weight. You also are going to feel horribly. So you're just eating bacon and hamburger patties, we'll say for 5 days, okay? Or 6 days, and on the 7th day you replete with carbohydrates and you keep repeating this. You're going to feel like garbage because the ketones, you're going to have this acidity in your body. And this diet was so strict that you would actually make sure that you're in ketosis by checking urine and make sure you're peeing ketones. This is an example of what these patients are going through. So diabetic ketoacidosis, we understand why it happens. We understand the pathophysiology. Now let's treat it. Let's keep it stupid. All right. I don't want you to be a red number warrior. So a lot of people say, oh, the potassium's 5.3. We need to treat it. No, we need to think about the patient first. So what are we thinking about? If this patient has nausea and vomiting, is their potassium levels going to be elevated? Probably not. It's very unusual for the total body potassium to be elevated in DKA because guess what? You don't have the insulin to get it inside the cells. So you're going to have what? The serum potassium is going to be elevated because it's sitting outside the cells. It's not getting inside the cells. And actually this patient, a lot of times when you start people on insulin, you'll see, and there's no perfect way to measure it, is that the serum potassium will drop from 1, like say if it's at 5, start at 1 at 4, it can drop up to 2. I've seen it up to 3 severe cases where this potassium, if you think it's 5.3, it really is 2 point something once you initiate the insulin. You need to get fluids. Mind the potassium, as we discussed. This is how people are executed When they used to do lethal injections, it was by giving too much potassium. But if you take too much potassium, take your potassium away rapidly, these patients will die. They'll have a tachyarrhythmia and die. They're already not doing well. You will get a horrible tachyarrhythmia and die. Usually in DKA, you do not have to worry. It's very unusual to worry about hyperkalemia. It may happen, but it's less likely. Starting glucose. This is your enforcer. This is your transporter molecule. This is your transporter, like the movie. You're enforcing. You're putting insulin. Insulin's putting the glucose inside the cell. This is to keep you going. This is everything you do. You're getting this. You want to keep this guy going. Now, there's different ways of doing the insulin drip. The easiest way is starting at 0.1 unit per kilogram, and you have this set amount. So if they're 80 kilograms, you do 8 units of insulin. You keep that insulin flowing. What you're watching is the blood glucose levels, and you're making sure that your blood glucose levels don't drop too fast. Minus sodium. So remember, the sodium we're going to have that issue of pseudo-hyponatremia, because we're going to have the glucose, the excess amount of glucose is going to what? It's going to cause problems for the module, for the sodium in checking it in the labs. So you would do is the correction. There's multiple formats you can do, but basically for every 100 over 100, you multiply it by 1.6 or 2.4 or a number in between, basically 1.6 to 2.4, and that is going to get your range of what the actual sodium should be. And there's multiple formulas that you can use for correction for that. And then you look for resolution. The resolution is going to be first of all, is your bicarbonate level, serum bicarbonate level greater than 18. Your anion gap is closed. And the most important one people forget is the patient has to be able to eat, because if they're still vomiting, you're going to come out of DKA. And resolution, you would give a long-acting insulin, and then 2 hours later, you cut off your drips, your insulin drip and your other drips. You give the long-acting insulin, and 2 hours later, you cut off your drips. You need to make sure that you have long-acting with short-acting insulin. And then the most important thing is they need to have diabetic education before discharge, because you want to avoid DKA from happening again and these patients coming back into the hospital, because it costs the system billions of dollars. Clinical scenario: a 47-year-old female found with altered mental status by her daughter at home. Remember, when you alter mental status, what are some labs we can get? B12 level, ammonia level. You can consider syphilis, HIV, depending on the area, patient, population. How about TSH? Well, the TSH came back, showed an elevated TSH with a low free T4. We'll discuss what this is. Remember something I just want you to know is the half-life of oral levothyroxine is roughly about 7 to 8 days. Okay, a 78-year-old female with history of Hashimoto's thyroiditis is brought to the emergency department in January with confusion. She had hypothermia with her core temp was 32 degrees Celsius, bradycardia, hypertension, and hypoventilation. Laboratory studies show hypernatremia, but she also had an elevated TSH and a low free 4. Now, normally we read the question step first. Today we did a little bit differently. What is the following is the most appropriate initial management? Oral levothyroxine, intravenous levothyroxine, empiric intravenous glucocorticoids, oral levothyroxine, immediate external rewarming, intravenous broad spectrum antibiotics only. Now, is this a fair question? Probably not. Probably not, because there's a lot of possible correct answers. What is Hashimoto's thyroiditis? Is a chronic autoimmune disease in which the immune system targets and destroys the thyroid gland tissue, leading to progressive hypothyroid dysfunction, and is most common hypothyroidism. It's characterized by lymphocytic infiltrate of the thyroid with presence of thyroid-specific autoantibodies. All right, so what's the answer to this? The answer is going to be IV levothyroxine, empiric intravenous glucocorticoids. This is myxedema coma, which should be treated first. Always look at this. It's very important for board questions and for life questions. Real life stuff. Get the intravenous glucocorticoids first, then you give the intravenous levothyroxine. Due to the risk of concomitant adrenal insufficiency, oral therapy is not going to be recommended. This lady's almost comatose or could be comatose. This is T3 right here. Guess what? T3 is not recommended, can cause harm, especially in an older person, can cause tachyarrhythmias. The other thing too is because it costs more money, guess what? Most hospital systems avoid carrying it nowadays. Now, this could be on, this one too, you could say is external rewarming. Is this a fair question? Probably not. And intravenous broad spectrum antibiotics, well, you probably put these, but we're going to say what is the most appropriate initial management would be this. And I guess you could say the same thing on external rewarming. We're going to do the initial. Not the greatest question in the world, but guess what? You're going to have a lot of board questions, and a lot of board questions are not going to be fair. Get over it. Myxedema coma. It's a rare manifestation of hypothyroidism with a low T4 level and a high mortality if delay in treatment occurs. Most common to occur in elderly women. Mortality rate is 20 to 25%. Despite treatment, this can cause this as MI, infarction, stroke, trauma, GI bleed. Myxedema coma, continued discussions. Mental status changes. Hypothermia is commonly present. You can have temperature less than 34.4 degrees Celsius and is present in nearly all patients. Lethargic, stupor, coma, depression, psychosis can occur. Seizures can also be present rather than coma. Decreased ventilatory drive with hypoxia and hypercapnia. A lot of these patients will end up on the ventilator. Can have bradycardia, hypoglycemia, hyponatremia, and hypotension as well. More discussion on myxedema coma. Diagnosis with a TSH and T4 levels checked immediately along with serum cortisol levels to help rule out concomitant adrenal insufficiency. Because the cortisol levels, they're not the greatest accuracy, you're just going to start the steroids right away. Waiting for the cortisol levels, just go ahead and give the high-dose glucocorticoids, which can be discontinued if not needed afterwards. Treatment, mechanical ventilation if required, if they're not protecting your airway. Vasopressors if the MAP is less than 65. Remember, MAP is 2/3 diastolic plus 1/3 systolic plus the glucocorticoids. Warming, intravenous fluid and warming blankets. You can give warming through that. IV levothyroxine treatment. And now the dosing may need to be adjusted in somebody who's older, and you may need to get your endocrinists some help from endocrine to assist in dosing. You want to do lower dosing in people who are older because you can have risk for cardiac arrhythmias and heart attacks, especially in patients with underlying cardiovascular disease. So the dosing would be, this higher dosing would be on more of a patient who's of younger age and of good health. And then treatment of T3 is not recommended. There's a higher risk of adverse events, including cardiac arrhythmias and heart attacks with this too. A lot of systems avoid carrying it because it costs more money and there's not really any, they feel the indications are very low, or they may put it behind a firewall where only an endocrinologist can prescribe it. All right, now let's talk T4 to T3 conversion. Now, if you go to our deep dive lecture, we have more in-depth analysis and breakdown of this material. But remember, T4 to T3 conversion, T3 is going to be a more active form. And conditions that impair peripheral conversion of T4 to T3, systemic illness, malnutrition, older age, medications such as propranolol can do this, PTU, which is used for treating of hyperthyroidism, iodinated contrast. Contrast can do this because the high amounts of iodine in the contrast. Amiodarone, you can add that to there too. When T4 to T3 conversion is impaired, you have your reverse T3 is increased. You have low T3 levels does not always indicate hypothyroidism. No role in measuring T3 and evaluating hypothyroidism. So if T3 is one of the answer stems in a board question, it's probably the wrong answer. Avoid answering T3, so always avoid. 27-year-old presents with tachycardia. This is pretty vague. This patient has a fever, tachycardia, altered mental status, having some nausea, vomiting, cardiovascular issues, high blood pressure, and they have a low TSH and a high free T4. So opposite, low TSH, high free T4. Let's go to an unfair board review questions.